general types of TMJ surgery for patients. Let them understand what it is that they're looking at. What's offered in regards to TMJ surgery?
Well, there's a range from minimally invasive to maximally invasive.
Right.
Okay, so minimally invasive would be more or less procedures to lavage the TMJ. And it could be as simple as flushing the joint with an IV fluid. Okay.
What fluid should they avoid?
Well, Ringer's lactate is typically pretty well tolerated. In terms of what to avoid, probably steroids. The steroids can have a lot of local irritation to the joint. So at any rate, in terms of invasive procedures, lavaging the joint would be the simplest. Mm-hmm. Now you can take that a step more complicated, and you could use an arthroscope as part of lavage, and then an arthroscope as part of surgery. So with the arthroscope, some surgeons are just lavaging the joint, selectively injecting steroids. Other surgeons may be using the arthroscope to try to eliminate scar or try to repair and reposition the disc and so forth.
Right.
So those are the simple procedures at the simple end of the spectrum. And some surgeons use them diagnostically. So they may not do an MR. They may use the arthroscope as direct visualization and diagnosis. The other end of the spectrum is what we do to bone, okay? And in a nutshell, we either reinforce or replace bone. So the question is, what's the condition of the condyle? And does something have to be done to replace the condylar head or do a bone graft to it or something like that? So that's this end of the spectrum out here. And then there's the middle ground, what I refer to as the middle ground. And the middle ground is working with soft tissue. And that means one of two things. You either keep the disc or you replace it.
Right.
Okay. Keeping the disc is probably the premier technique.
Yeah.
So that's trying to take the original tissue and the original anatomy that has been altered with injury, and you try to return that anatomy back to normal. So in my opinion, a disc repair is the best thing that we can do for a patient.
Right.
But here's the problem. Many times patients aren't even diagnosed for several years.
Distortion.
And there's distortion in the disc, there's weakening of ligaments, and they end up with a non-repairable disc.
Right.
So what happens from there is surgeons may come up with different solutions to find a disc substitute, or they may not put anything in at all. I, through the years, have gravitated towards fat as the substitute for the disc. So, you know, when you're talking to a patient about their options, everybody hopes they don't have to do anything.
Sure.
And the reality is you have some people who really have very minimal mechanical damage. And so could they be a candidate for a lavage? Yeah. I'll talk about that more in a minute though. Would they be a candidate for a joint replacement? No. Why? You know, if their condyle has good surface area, why would you do that? My opinion is that there are too many people having bone replacement. Right. There are too many people having total joint replacement. And I look at them and say, why would you replace a condyle that it looks normal? It's got a good surface area. Now, linking concepts, I suspect that the answer is that the surgeon feels like they're going to have repeated surgical failure to the point they're going to be replaced anyway, so you might as well jump ahead and do the joint replacement. The other thing is a lot of these patients have crypts and undiagnosed crypts, and so the joint replacement is done for that reason. I would make a general statement. The bone is not the enemy, okay? We don't have to sacrifice the bone because it's the source of evil. It's not, okay? The condylar bone is a bystander that's altered by injury. It's altered by injury from a dislocated disc in a child, then the bone doesn't grow as big. The bone is a bystander for blood supply interruption, whether it's mechanical interruption of blood supply or whether there's crypts creating a vasoconstriction. If the condyle doesn't get enough blood flow, it'll undergo necrosis. Yeah. If a condyle is overloaded, it's going to have osseous remodeling in different types of degeneration like osteochondritis dissecans or superficial degenerative arthritis just from mechanical loading. But in general, the condyle is very adaptable in the system if it's reasonably protected. So in my own practice, I'm not too keen on doing a replacement of a condyle unless that condyle is extremely small. Because I really find that we can typically get most condyles functional. And we have a model for this. I mean, we have patients who have had unilateral condylar fractures, yeah, and surgeons for years never treated them, okay, because they realized that most of those patients, they may be a little bit crippled and limping, but they can adapt to that type of an injury. And so you don't have to necessarily replace the bone at this end of the spectrum. At the other end of the spectrum, the question is, do we have to lavage them? Do we really have to wash the joint out?
Yeah.
And if you think about what happens with a lavage, the joint's also anesthetized. So is it blocking it with the anesthetic, or is it the procedure?
Right.
See, that double-blind study has never been done. That's crying to be done.
Yeah.
And it may well be that simply doing a nerve block does what we think we have to do with a lavage. Now, the rationale for lavage is that the joint mechanically is not moving, it's sticky, okay? But you and I both know, if you don't even block the TMJ, if you do a greater auricular nerve block right here, what's range of motion do?
Increases.
It increases. It typically increases all the way up into the 40s.
Yep.
And you see the dystonia turn off like that.
Yeah.
So again, we have insight that there is a cause and effect. You do this, the effect is going to be that, but it may not be exactly what you think if you've got cofactors that are part of a procedure. Okay? So the reality, a lot of people are in that middle ground. They have mechanical injury.
Yeah.
And the mechanical injury is driving their pain. It may be driving a change in the bite. It may be driving crypts. You know, they may be fairly debilitated. Do those patients have answers? And the answer is, yeah, they do. If we can preserve what they have, then it's a repair. If we can't preserve what they have, then you replace what can't be preserved. Okay? You could take that attitude to the soft tissue and to the hard tissue.
Soft tissue being the disc,
Soft
hard
tissue being the
bone.
disc. Yeah. If you could repair it, you keep it. If you can't repair the soft tissue, you replace it. My opinion is best replacement is fat. Take that to the bone. Can you repair it and protect it, or do you have to replace it?
Right.
Well, if you can preserve the bone, there's no reason to replace it. If you have to replace it, then you pick your favorite procedure to do that. So, to me, again, the extreme, the total joint replacement, if you understand how to treat pain, and sympathetic pain in particular, and if you can put your confidence in techniques that can protect the condyle that's there, then there are fewer candidates to have to replace the bone.
The problem is, though, insurance, right?
Well, no, I think the problem is choice of the surgeon. The surgeon can still stand up to the insurance company.
Okay.
If an insurance company is telling a surgeon what to do, the surgeon may have to occasionally stand up and say, no, I won't do that.
Yeah.
Okay. So the insurance companies sometimes are not fair, and sometimes they are. So I think a lot of times insurance companies want a good diagnosis. You know, they want to know what are we doing here? What are we replacing? Or why are you doing what you're doing? And in the surgery world, there is as much conflict of opinion as there is in the non-surgical world for treating TMD. Okay? It's the same.